Hello and welcome to CLP's webcast, Who, How, and When to Test for H. pylori Infection, sponsored by Meridian Bioscience. I'm Chris Wolski, CLP's Director of Business Intelligence, and I'll be the moderator for today's presentation. At the conclusion of today's presentation, we will have a short Q&A with the webinar's presenters, Dr. Stephen Moss and Colin Howden. So to that end, please at any time, feel free to submit a question via the Q&A box on your screen. Those questions that aren't answered will be addressed directly by Drs. Moss and Howden and the Meridian Bioscience team after the conclusion of the webinar. Now, today's webcast is being recorded, and you will all receive an email with a link to the recording shortly after the end of the presentation. It will also be available for new registrants to watch on GoToWebinar for the next 3 months. So if you know of any friends or colleagues who missed out, please let them know that they can listen to the recording. Now, it's my pleasure to introduce you to today's presenters, Dr. Stephen Moss and Dr. Colin Howden. Dr. Moss is currently a professor of medicine and the program director of the Gastroenterology Fellowship Training Program at Brown University. He is also the director of endoscopy at Providence, Virginia Medical Center. Dr. Moss's research has for many years focused on the basic and clinical aspects of H. pylori infection. He has received awards and research funding from the American Gastroenterology Association and several NIH grants for this research, and has co-authored the 2017 and 2024 U.S. guidelines on H. pylori management, and is a member of the Maastricht group that develops international guidelines for H. pylori. He has over 200 peer-reviewed publications, served as a consultant to the WHO, has served on the editorial boards of multiple gastroenterology journals, and as a counselor of the American Gastroenterology Association. He is a member of the Royal College of Physicians in the UK, an American Gastroenterology Association Fellow, a Fellow of the American College, and a Fellow of the American College of Gastroenterology. Now, Dr. Howden is Professor Emeritus in the Department of Medicine at the University of Tennessee College of Medicine. He previously served as the Hyman Professor of Medicine and Chief of the Division of Gastroenterology at the University of Tennessee Health Science Center from 2014 to 2021. He has over 260 peer-reviewed articles to his credit and currently serves as the editor of Alimentary Pharmacology and Therapeutics. He is a fellow of the American Gastroenterological Association, American College of Gastroenterology, American College of Physicians, American College of Clinical Pharmacology, and the Royal College of Physicians and Surgeons of Glasgow. So without further delay, I'll hand the presentation over to Dr. Moss. So Dr. Moss, take it away.
Well, thanks very much. It's a pleasure to be here with my good friend Colin Howden, and we both were on the authorship list of these recent ACG guidelines. That is the focus of today's presentation. Next slide, please. So here are our objectives: to review the epidemiology and disease associations of H. pylori, to understand the indications for testing for H. pylori, to review and implement the appropriate testing strategies, and then to identify appropriate treatments for both treatment-naive patients, people who've never been treated for H. pylori, and treatment-experienced patients with H. pylori infection. Next slide. So we're going to start talking about epidemiology and disease associations. Next slide. So I think many people are familiar with the story of how H. pylori was discovered or identified back in the early 1980s by two Australian physicians in Perth. On the left of that picture is Robin Warren, who was a pathologist, and he'd observed many bacteria in the stomach, and he couldn't get anyone to work on his research project, but he managed to recruit Barry Marshall on the right of that picture, who at that time was a medical resident, to get involved in his research project. And they together cultured H. pylori for the first time, identified that it was closely associated with ulcer disease and speculated that it had something to do with gastric cancer. So at the time, the medical establishment was not really ready for such a revolutionary idea. Peptic ulcer disease was thought at that time to be related to psychological stress and acid hypersecretion. But ultimately, they persuaded everyone that they were right, and 22 years later after their discovery, they ultimately shared the Nobel Prize for H. pylori's role in peptic ulcer disease. Next slide. So this is what the organism looks like. It's a gram-negative spiral bacterium. It has a number of flagella at one end of it, which allows it to swim around in the mucus overlying the gastric epithelial cells, which line the inner part of the stomach. It causes an intense inflammatory response in the mucosa or lining of the stomach, and it's this inflammatory response which ultimately can lead to loss of gastric glands, so-called atrophic gastritis, peptic ulcer disease, and in some cases, gastric cancer. Next slide. About 1/3 of the adult US population is infected by this organism, and studies have shown that typically this first infection occurs in childhood in the first few years of life, and typically, certainly by the time a child turns 10 years of age is the time when they tend to be infected. Once infected, duration of infection is lifelong. Until for the next 7-8 decades, we're going to be living with H. pylori inside our stomach unless we have a combination antimicrobial treatment to eradicate it. The prevalence is much higher in racial and ethnic minorities in the United States, probably mostly because these are people who themselves or their parents have migrated from high prevalence countries carrying the H. pylori with them. The way that H. pylori is transmitted from person to person is mainly through the fecal-oral route, like the same way that many enteric organisms are transmitted. But gastric oral transmission has rarely been identified, and even waterborne transmission is occasionally reported in the literature. The risk factors for the acquisition of H. pylori in this country and in other places in the world are associated with living in crowded conditions with poor sanitary conditions. Next slide. This is a rather complicated slide, so I'm going to take you through this slowly. On the x-axis is time from childhood through to advanced age, and on the y-axis is the degree of acid production from the stomach. So H. pylori is typically acquired in childhood on the left-hand side there of the slide, and when it infects, for the first few weeks and months during the acute infection, acid production is inhibited and is quite low, but then it later recovers within months, and chronic H. pylori infection is almost always established as a consequence of the acute infection. Following this, over the next decades, there are a variety of different outcomes, partially related to which part of the stomach is involved in the infection. So at the top of that middle part of the slide, if the infection mainly remains in the antrum, the most distal part of the stomach, acid secretion tends to be high, and this is the phenotype associated with duodenal ulcers. At the bottom of that section, if the infection affects mainly the body or the corpus of the stomach, the top part of the stomach, this is the phenotype that is associated with low acid secretion, and these patients are at risk for gastric ulcer, intestinal metaplasia, and other pre-neoplastic gastric changes, which can ultimately result in gastric cancer as the patient gets older. You'll also see on that slide the malt lymphoma on the top hand side. This is a rather rare outcome of H. pylori infection, and we'll talk about this more on the following slide. Next slide. So these are the diseases and conditions associated with H. pylori infection. So first of all, gastritis. So H. pylori infects the stomach and always produces an intense inflammatory response. So this gastritis is a histological or tissue diagnosis. If you take a biopsy from anyone infected with H. pylori, they will have gastric inflammatory cells, though this is not necessarily associated with symptoms. And in fact, most people who have H. pylori infection don't have any symptoms, even if they're followed for many years. About 1 in 7 people infected by H. pylori will develop a peptic ulcer. And then even rarer is the development of gastric cancer or adenocarcinoma, which occurs in about 1 in 100 infected individuals. So you can see that gastric cancer is a rather rare outcome following H. pylori infection, but seeing that 5 billion people on the planet approximately are infected with H. pylori, you can see that there is a lot of gastric cancer. And in fact, gastric cancer is one of the most common causes of cancer mortality throughout the world. Much rarer than adenocarcinoma is this MALT lymphoma, MALT standing for mucosal associated lymphoid tissue lymphoma. This is a malignant proliferation of the lymphocytes which are recruited to the stomach wall during H. pylori infection. This is rare, but remarkably, this lymphoma can melt away if H. pylori is eradicated successfully. And patients with MALT lymphoma treated to eradicate their H. pylori, the vast majority will have no recurrent disease, and we have follow-up studies now going on for 20 or 30 years to show that that is the case. Another condition associated with H. pylori is dyspepsia, a symptom complex of pain or discomfort centered in the upper abdomen. So in some cases, patients with upper abdominal discomfort have H. pylori as the cause, and this can be substantiated by eradicating H. pylori in these patients, and about 10% of them will have resolution of their symptoms. So H. pylori is a cause of dyspepsia, but there are many other causes, so it does not always respond to H. pylori eradication. Next slide. This slide talks more about gastric cancer, which is really the most important outcome of chronic H. pylori infection. Many studies over the last 20 or 30 years have shown that H. pylori is the #1 risk factor for gastric cancer. So about 80 to 90% of all gastric cancers on a global basis are directly related to chronic H. pylori infection. The International Agency for Research on Cancer, which is a branch of the World Health Organization, classified H. pylori as a group 1 or definite carcinogen back in 1994. And since that time, the evidence has just grown stronger and stronger that this is the case. There have been a number of randomized double-blind controlled trials of H. pylori eradication to see if it will reduce the occurrence of gastric cancer. And these studies, which have been performed mainly in Southeast Asia and South America, have shown that H. pylori eradication will lead to about a 50% reduction in gastric cancer development. Now, we don't have good double-blind placebo-controlled trials from these studies from the United States, but we do have some observational studies, such as this one shown here from the University of Pennsylvania, in which over 1/3 patients in the VA Health Administration database who had H. pylori infection were followed over the next 20 years or so. And in this observational study, those patients who had confirmed eradication of H. pylori had about a 75% reduction in the risk of gastric cancer compared with those patients who had H. pylori that was not eradicated over the 20-year period. Next slide. So now we're going to talk about testing for H. pylori infection. Next slide. So here is the important principle about testing for H. pylori, is that anyone who is tested and found to be infected should be offered treatment. So you shouldn't do the test unless you're ready to prescribe the treatment if the test is positive. And after treatment, because our treatments, as we shall discuss later, are certainly not 100% effective, we should retest to see if the treatment was successful. And if it wasn't, retreat and then retest. Next slide. So who should be tested for H. pylori infection? On the left-hand side of the slide are the indications for H. pylori infection that have basically been the same for the last 10 years at least. So these are patients with ulcer disease, malt lymphoma, gastric precancerous changes, or people who've had a personal or family history of gastric cancer because of these close associations of these conditions with H. pylori. There's also unexplained iron deficiency in patients with iron deficiency anemia after they've had testing, colonoscopy, upper endoscopy. If no other cause can be found for their iron deficiency other than H. pylori, the H. pylori should be treated because H. pylori can interfere with iron absorption and can lead to iron deficiency. H. pylori is responsible for a small proportion of cases in this country of ITP, idiopathic thrombocytopenic purpura. So it's well worth testing for H. pylori in ITP patients, and those that are positive will, about 50% of them will have a benefit in terms of platelet count from eradicating H. pylori. We know that H. pylori is synergistic with non-steroidal anti-inflammatory drugs and aspirin in terms of causing ulcers and making ulcers bleed, so that all patients who are starting long-term NSAIDs and long-term aspirin, including low-dose aspirin, should have H. pylori evaluated and tested for, and again, eradicated if it's positive. And as we've discussed, some patients with dyspepsia symptoms do benefit from H. pylori eradication. So patients with dyspepsia should be tested for H. pylori and treated if positive. Now, on the bottom right of this slide are a couple of additional indications for testing for H. pylori that have been added on in the ACG guidelines that have just been published. So firstly, adult household member contacts of H. pylori individuals. So because of this intrafamilial transmission, we know that H. pylori is more prevalent in first-degree relative or household members of those who have already been diagnosed with H. pylori, and there is benefit from eradicating H. pylori in those patients after screening them. The second group that we thought it should be encouraged and recommended to screen are non-white racial and ethnic groups. So these groups all have an increased risk of gastric cancer relative to the white racial group in this country. They have an increased prevalence of H. pylori, and they have an increased risk of gastric cancer. So we're not yet at population-based screening, but we are recommending screening based on people's racial and ethnic background. Next slide. So now we're going to spend some time going through the various tests for H. pylori infection, and this can be confusing because there are so many of them, but we'll try to make it logical. So firstly, we'll talk about the tests that can be done at the time of endoscopy to evaluate if H. pylori is present. So many patients will undergo endoscopy for abdominal pain, dyspepsia, bleeding, and so on. And it's relatively easy to take biopsies at the time of endoscopy and to evaluate for H. pylori. The most common way this is done currently is through taking a biopsy for histology. The pathologists will process it for H&E staining, and often the organisms can be seen just by hematoxylin and eosin staining. If there's a question, if there's inflammation, but the organisms are not easily seen, then some special stains can be added on, including the silver stain shown there on the bottom right, those little black squiggles being H. pylori organisms, or immunohistochemistry is another way to make the organisms more obvious. The biopsy urease test has fallen out of fashion in recent years because it lost some sensitivity, but this is a relatively easy bedside test that can be done. So the biopsy obtained at the time of endoscopy can be put in a pH medium indicator. H. pylori produces a lot of urease enzyme, which metabolizes the small concentration of urea, which is in the gastric lumen. And one of the products of this is ammonia. So H. pylori alkalinizes its medium and can be put in a color indicator, and you get a color change from yellow to pink within a few hours with a biopsy urease test. The third method of diagnosing H. pylori at the time of endoscopy is by bacterial culture. This is the standard way that we diagnose many bacterial infections, respiratory infections, urinary infections, and so on. And it's possible to do this for H. pylori, but it's not easy, takes a long while, and it's receiving a bit of a comeback now, however, culture, because of the issue of antibiotic resistance, because culture allows one to detect antibiotic resistance patterns, which we'll come back to talking about in a few minutes. And finally, there are a variety of molecular tests have been developed in the last few years, including next generation sequencing. And these all have the ability not only to diagnose H. pylori, but probably more importantly, to work out resistance patterns using the genotypic fingerprint obtained during sequencing. Next slide. So those are the tests that could be done at the time of endoscopy to diagnose H. pylori, but it's certainly not necessary to do an endoscopy just to diagnose H. pylori, because there are these two excellent tests, the urea breath test and the stool antigen test, which are excellent non-invasive ways to test for H. pylori infection. So the stool antigen test uses a monoclonal antibody on a stool sample. The breath test measures the urease activity in the stomach, which is a surrogate of H. pylori bacterial infection. And we'll look in a moment at the details of the urea breath test. Now, both of these tests have high sensitivity and high specificity. They have an asterisk next to them, and you can see that on the right-hand side of the slide, the asterisk is to say that these are excellent tests. However, to avoid false negatives with these tests, the patient needs to be off antibiotics and bismuth for 4 weeks and should be off PPI medications for 2 weeks, because all of these things lower the sensitivity of both the breath and the stool antigen test. Now, in patients who may have trouble getting off their PPIs for 2 weeks just for the purpose of this test, can go temporarily onto H2 receptor antagonists. These do not interfere with the sensitivity of the test. The third item on this non-endoscopic test is the ability to do molecular testing, including next generation sequencing on stool. And we'll talk about that more in a moment. But again, one can get sensitivities for antibiotic resistance profiles from H. pylori now from stool testing. Finally, serology. So serology used to be the way that we diagnose H. pylori infection, looking for an IgG against H. pylori, but it's no longer recommended for many years now because it has a poor sensitivity and specificity. And very importantly, it cannot distinguish past from current infection. So even in patients who have H. pylori successfully eradicated, may have positive antibodies for months or even years after successful eradication, because the antibodies stick around for way, way longer than the organism does. Next slide. Okay, this is the urea breath test and the basis behind this. So on the left, you can see that what's going on in the stomach. So the patient here will drink a solution of citric acid and urea, chemically synthesized urea. In the urea, the carbon atom of the urea is labeled with C13 instead of the normal C12. Consequently, if there's urease activity in the stomach, because there's H. pylori, the urea will be broken down in that reaction on the left. And one of the byproducts is carbon dioxide, in which the C is again labeled with the 13 that was put into the urea. Consequently, the C13, CO2, is blown off in the lungs and can be detected in the breath. And the machine on the right is typical of the kind of thing which we use to analyze the ratio of 13 CO2 to 12 CO2 in the breath over the next 15 minutes or so. So patient ingests the urea, breathes out, and if they have a high 13 CO2 to 12 CO2 ratio, it implies that they had urease activity in their stomach, which implies that they had H. pylori. And so although it's rather an indirect test, It's in fact very accurate for the detection of active H. pylori infection. Next slide. So finally, there are in recent years more tests coming for antimicrobial susceptibility related to the fact that this is more prevalent, antibiotic resistance in H. pylori than it used to be. So the standard way to do this used to be take an endoscopic biopsy on the top there, culture it. It takes 7 to 10 days, requires special medium anaerobic and blood agar and so on. And most hospitals have never did this or have stopped doing this. And so it's almost always required to send it out to a small number of commercial labs that offer this. And once they've grown up the H. pylori on the culture dish, you can measure phenotypic resistance. The issue with this test is that cultures sometimes fail to yield organisms, so you've got a definite H. pylori positive patient, but somehow by the time the culture gets to the receiving lab, they're not able to grow it. And I think that's the biggest problem with this, in addition to the fact it takes quite a long time to get a result. In recent years, it's possible to do next generation sequencing and PCR from gastric biopsies. This is more rapid and can be done in-house or commercially, and it will detect the mutations underlying antimicrobial resistance. So it'll give you genotypic basis of resistance rather than the phenotypic resistance. And then the third method on the bottom, as I mentioned before, it's now possible to do this next generation sequencing on stools. Similar to the gastric biopsies, you get a fingerprint of the mutations underlying antimicrobial resistance. It's not yet widely available. There's only one company offering it. The great advantage of this, of course, avoids endoscopy or repeat endoscopy, particularly in those patients who fail treatment and you're trying to figure out which treatment to offer them based on antibiotic resistance profiles. Next slide. So with that, it's my pleasure to pass the microphone over to Dr. Howden.
Okay, thank you, Steve. So my objective is to review some general principles of treatment for H. pylori infection and also to give you some updates on suggested and recommended treatments from the recently updated American College of Gastroenterology guideline. So next slide, please. And some general considerations, these really haven't changed much over the years. So our decision to treat H. pylori infection should be based on the result of a test of active infection. As Steve alluded to, serology is not adequate for this. So the decision to offer treatment should be based, for example, on a positive urea breath test, fecal antigen test, or biopsy-based test. As Steve said a couple of times, all people who are tested positive for H. pylori infection should be offered treatment. We know that sounds obvious, but we also know that this doesn't always happen. Treatments, as I'll show you, can be somewhat complicated, and therefore it's in the clinician and the patient's best interest that the treatment is explained in detail and the patient is made aware of possible side effects that he or she may encounter during the course of treatment. But what about the choice of treatment? Well, as Steve alluded to, if we had routine availability of antimicrobial sensitivity testing, we would use it. That's how we treat pulmonary infections and urinary infections, as he mentioned. However, at the moment, we don't have routine availability, so we have to make the best of the situation. We should certainly determine whether the patient has used a macrolide or a quinolone antibiotic for any reason in the past. And if they have used a macrolide, then we should not use clarithromycin to treat the infection. And if they have used a quinolone, we should not use levofloxacin to treat the infection. A number of adults in this country say that they are allergic to penicillin. We now know that the vast majority of them are not truly penicillin allergic. So unless the patient gives a history of an anaphylactic type reaction to a penicillin, it's sometimes beneficial to get an allergist involved to determine if there is true penicillin allergy, because amoxicillin, as I'll show you, continues to be an important part of our treatment armamentarium. And as Steve mentioned, treatment is not the end of the story. After treatment, patients should be retested. So remember, please, test, treat, and retest. Next slide, please. So the updated American College of Gastroenterology guideline published in September of this year recommended one regimen, which is summarized here. Thank you. This is so-called optimized bismuth quadruple therapy, and this was the only regimen that we felt comfortable in giving a strong recommendation for. And as the name suggests, there are 4 components to this regimen. Number 1 is an appropriately dosed proton pump inhibitor that should be taken twice daily before a meal. And there is some evidence that certain PPIs may be more suitable than others, for example, rabeprazole or esomeprazole, because their metabolism is not dependent on cytochrome P450 2C19. The other component, number 2 in the quadruple regimen, is a bismuth salt. There are 2 available in this country, bismuth subsalicylate and bismuth subcitrate. Obviously, the bismuth subsalicylate should not be used if the patient has an allergy to aspirin or other salicylate drugs. Number 3 is tetracycline. Rather than doxycycline, the dose of tetracycline should be 500 milligrams 4 times daily. And the last component is metronidazole, 500 milligrams 3 or 4 times daily. So that is a lot of capsules and tablets for a patient to take. Therefore, it is important that the patient understands why he or she is being recommended to take this. The patient must be encouraged to try and complete the 14-day course and to try and work through any minor adverse effects that he or she may experience. And all these are taken together for 14 days. Next slide, please. Why do we recommend bismuth-based quadruple therapy with tetracycline for 14 days? Well, this table is taken from a study performed by Dr. Moss and colleagues in Brown University in Rhode Island, looking retrospectively at a large number of patients treated at their clinic. They found that bismuth-based quadruple therapy containing tetracycline for 14 days in almost 600 patients gave the highest cure rate of around 87%. You'll notice that for any of the 3 regimens listed on this slide, reducing the duration of treatment from 14 days to 10 days resulted in a reduction in the overall cure rate. And at the bottom of the slide, although the numbers are limited, you can see that when doxycycline is used in place of tetracycline, the eradication rates are lower than when tetracycline is used. Next slide, please. Here are 2 other suggested regimens, or 3 actually suggested regimens for treatment-naive patients as per the recently updated ACG guideline. One is a proprietary preparation known as Talicia, which is a triple combination of omeprazole, amoxicillin, and rifabutin. And that was given a conditional recommendation with relatively low quality of evidence. And the other 2 were based on vonoprazan, which is marketed as Voquezna. Vonoprazan is the first PCAB, or potassium competitive acid blocker, to have been approved in the United States. The FDA has approved Talicia and the 2 Voquezna-based regimens, as you can see. One of the Voquezna-based regimens is a dual therapy with amoxicillin, and the other is a triple combination of vonoprazan, clarithromycin, and amoxicillin. Next slide, please. This algorithm is taken from the recent publication. So this is a summary of the treatment recommendations for treatment-naive patients, assuming that you do not have access to antibiotic susceptibility testing. So as I said earlier, it's important to ascertain if the patient is allergic to penicillin. If the patient does claim an allergy to penicillin, then this should perhaps be questioned and ascertained by routine allergy testing. And if allergy testing shows that there is not a true penicillin allergy, then the patient can safely receive amoxicillin as part of the treatment regimen. However, if the patient is allergic to penicillin, then optimized bismuth quadruple therapy is our recommended treatment. On the left-hand side, assuming there is no penicillin allergy, then optimized bismuth quadruple therapy would certainly be appropriate. Alternatives would be the rifabutin triple combination or the PCAB dual combination. There is also the possibility of using the PCAB clarithromycin triple combination, but that should be avoided if the patient has previously used a macrolide. Next slide, please. So, as Steve mentioned, antimicrobial resistance by H. pylori is an increasing problem, and this slide is a bit of restating the obvious. So point number one, as Steve mentioned, H. pylori infection is usually acquired in childhood. Point number two, to really restate the obvious, H. pylori lives in the stomach. Therefore, H. pylori has been exposed to every antibiotic that person has consumed since childhood. So if the patient had received, let us say, clarithromycin for a pulmonary infection some years ago, the H. pylori, of which the patient was unaware, has been exposed to clarithromycin and may well be clarithromycin resistant. Next slide, please. Again, this is a study from Dr. Moss's group in Rhode Island. This looks at the pooled prevalence of resistance to various antibiotics determined from testing isolates of H. pylori over a decade. And you can see that the pooled prevalence of clarithromycin resistance was over 30%. And clarithromycin resistance is an absolute phenomenon. So if it's present, it really doesn't matter how much clarithromycin you throw at it, you're not going to eradicate the infection. Looking towards the bottom of this table, you can see that, resistance rates to amoxicillin, tetracycline, and rifabutin are much, much lower than that. And that emphasizes the important role of amoxicillin as part of some treatment regimens. Somewhat worryingly, at the bottom row of the slide, you can see that the prevalence of dual resistance to both clarithromycin and metronidazole was almost 12%. Next slide, please. A recent clinical trial, in fact, this was the trial that led to the approval of the vonoprazan-based regimens for H. pylori infection. This involved 103 sites across the United States and Europe, with over 900 treatment-naive patients. And you can see that in the US, the overall prevalence of clarithromycin resistance was 22%, ranging from about 15 to 25% across different regions of the states. Amoxicillin resistance was much, much lower, overall about 1.2%. Again, emphasizing the importance of amoxicillin. Next slide, please. This is taken directly from the 2024 update of the American College of Gastroenterology guideline. Again, there's nothing new here, but we really need to emphasize this concept about post-treatment testing. So all patients who are treated for H. pylori infection should undergo a test of cure with an appropriately conducted urea breath test, fecal antigen test, or biopsy-based test at least 4 weeks after completion of therapy. Again, the maxim test, treat, retest. Next slide, please. What about salvage treatment? Well, as Steve mentioned and as I showed you, our treatments are not 100% effective. So some patients are going to be left with persistent H. pylori infection after one course of treatment. The first thing to remember is that symptoms do not predict post-treatment status. A patient may have presented with dyspeptic symptoms, been found to be H. pylori positive, treated for H. pylori, but comes back with persistent dyspepsia. That does not mean that the patient is still H. pylori infected. And so persistent infection needs to be documented either with the urea breath test or a fecal antigen test, not with serology. It should go without saying that if the patient received clarithromycin or levofloxacin first time around, then the second treatment regimen should not contain either of those drugs. Again, it's very important to discuss with the patient the importance of closely adhering to treatment, the importance of completing the 14-day course, and make sure that the patient understands what potential and expected adverse events may occur with treatment. Next slide, please. Again, this is one of the algorithms taken from the recent ACG practice guideline, recommending salvage regimens for treatment-experienced patients, assuming that you do not have access to antibiotic susceptibility testing. On the left-hand side, you'll see that patients who had previously been treated with PPI clarithromycin triple therapy. Now, neither Dr. Moss nor I nor any of our co-authors would recommend PPI clarithromycin triple therapy today, but we recognize that this is still the most frequently prescribed treatment for H. pylori infection in this country. So if the patient has failed that, again, the first question is there true penicillin allergy? If there is not, then optimized bismuth quadruple therapy is there. Also, other possibilities, rifabutin triple therapy, or the combination of a PCAB with amoxicillin, or perhaps a high dose of a proton pump inhibitor with amoxicillin. If the patient is truly penicillin allergic, optimized bismuth quadruple therapy. Looking to the right-hand side of the algorithm, perhaps the patient received bismuth quadruple therapy, but in a less than optimized combination. Perhaps they received doxycycline instead of tetracycline, or they didn't complete the full 14-day course. Then again, if there's no penicillin allergy, any optimized bismuth quadruple therapy is still recommended, with the patient being strongly encouraged to complete the whole 14-day course. And alternatives would be rifabutin triple therapy, or the combination of a PCAB and amoxicillin, or a high-dose proton pump inhibitor and amoxicillin. If the patient previously received non-optimized bismuth quadruple therapy and is penicillin allergic, then optimized bismuth quadruple therapy still pertains because it doesn't contain amoxicillin. The observant amongst you will have recognized by now that optimized bismuth quadruple therapy is rarely the wrong answer. Next slide, please. For patients requiring salvage treatment, and there is availability of antibiotic susceptibility testing, then the treatment to be recommended depends on the results of that test. On the left-hand side, if the organism is sensitive to both clarithromycin and levofloxacin, you have multiple options available, including clarithromycin-based triple therapy. And really, this is the only situation in which we would recommend clarithromycin-based triple therapy. That is when you have documented proof that the organism is clarithromycin sensitive. Otherwise, clarithromycin should not be used for the treatment of H. pylori infection. If the bug is resistant to clarithromycin but sensitive to levofloxacin, then again, optimized bismuth quadruple therapy, rifabutin triple therapy, or last choice, levofloxacin triple therapy. I say last choice because levofloxacin triple therapy has less evidence in support of it, and there are safety concerns with levofloxacin, including such things as tendinitis and tendon rupture. So we would reserve levofloxacin triple therapy if there were no alternatives available. Moving along, if the bug is sensitive to clarithromycin but resistant to levofloxacin, then again, clarithromycin triple therapy would be appropriate in that situation, but so too would optimized bismuth quadruple therapy and rifabutin triple therapy. And lastly, if the bug is resistant to both clarithromycin and levofloxacin, you still have some options. Again, optimized bismuth quadruple therapy, the rifabutin triple regimen, or perhaps a high-dose PPI or a PCAB with high-dose amoxicillin. Next slide, please. So in summary, H. pylori causes chronic infection. It's often asymptomatic, but as Steve showed you, it can have some serious consequences long-term, including peptic ulcer and gastric cancer. We should have a positive test for active infection before we decide on treating H. pylori infection, and that would mean a urea breath test, a fecal antigen test, or a biopsy-based test. In the absence of antimicrobial sensitivity testing, we have to choose the treatment regimen carefully. It's very important to know the patient's personal antibiotic history and avoid clarithromycin if the patient had received a macrolide at any time in the past. In fact, we should only be using clarithromycin if we have documented evidence of susceptibility to it. It's important to spend some time with the patient to discuss the importance of adherence with treatment and describe what possible side effects may be encountered during treatment. Encourage the patient to try and work through these if at all possible. I'm hopeful, as I think Dr. Moss is, of the future more widespread availability of antimicrobial sensitivity testing, and hopefully that will have a positive impact on our ability to offer rational treatments to our patients. And again, for about the third or fourth time during this talk, I would say that it is very important that patients should be retested at least 4 weeks after completion of treatment, and that should be with a urea breath test or a fecal antigen test, or if the patient requires endoscopy for a clinically valid reason, then this can also be done by endoscopic biopsy. Thank you for your attention, and I'm sure Steve and I will be pleased to take any questions that you may have.
All right. Well, great. Thanks to both Dr. Moss and Dr. Howden for this excellent presentation. We do have some time left, so let's answer some of those questions that came in during the presentation. Now, if you haven't already asked a question, we still have opportunities to do so. So please input your questions in the Q&A chat box on your screen. So, all right, so when choosing a non-invasive test, is there an advantage to using one test versus another, such as urea breath versus stool testing? I know you kind of went over all of the different kinds of testing, but how do you make the choice between one or the other?
I'll be happy to have a go at this.
Okay.
I think they're both very good non-invasive tests, and from a scientific point of view, I don't have a feeling that one is better than another. So
Okay.
I'm happy. It's often a question of availability of the test in your office or in your hospital. If it was left to me, if I was the patient, which one would I rather have? I'd probably go for the breath test rather than tests involve me sending stool to a lab, but that's just my personal bias. They're both excellent tests.
Okay, great. And you talked a little bit about availability too. There's also what's available for the organization that who may be testing you as well. You outline that as well, right?
Correct.
So that
yes.
that might be an issue as well, right?
That's right. So it may be cheaper for an organization to prefer a stool test because the patient doesn't require an assistant or a technician. They just deliver that to the lab.
Right.
Whereas the breath test requires usually someone sitting in the room or intermittently going into the room to make sure that the test is being conducted in the proper fashion.
Right. Got it. All right. There's another one. Do you have any recommendations? I guess maybe this is for Dr. Moss again. Do you have any recommendations on how to implement an algorithm for testing family members of patients who test positive for H. pylori?
No, there's no algorithm.
Okay.
But I would say someone who's living with other adult members, once the index case has been identified, then the other adult members in that family should be tested and treated if positive. We're talking about adults. Children is a little different. The pediatric guidelines do not recommend testing and treating children of adults with infection. because infection in children can sometimes be transient, and so they would rather wait until they're adults and have established themselves to be positive or negative. And particularly if they have disease, if they undergo endoscopy, that would be the time to biopsy. So the pediatric guidelines are somewhat different.
Okay. And this is for either Dr. Howden or Dr. Moss. Are patients typically able to avoid bismuth or PPI for 2 weeks?
Well, it really depends on why the patient is on a PPI. If the patient is taking a PPI for dyspeptic symptoms, for example, then in my experience, it's generally fairly straightforward to get them to discontinue that for the purposes of the test. Sometimes the patient is taking a PPI for reflux symptoms, and I don't know if we want to get into the difficult possible association of reflux with H. pylori, but again, if it's really important to know the H. pylori status, it's relatively straightforward to persuade the patient to temporarily discontinue the PPI. And as Steve mentioned, they can certainly take a standard dose of an H2 receptor antagonist that would not interfere with either the stool test or the breath test.
Okay, got it. Here's another one. Okay, so this person who sent this question is that we work with the Native American population that has a high prevalence of H. pylori. One of the slides during the presentation mentioned screening. Would this be recommended for all Native Americans or only those with symptoms?
Well, the update to the guideline greatly expanded the list of suggested populations for testing. As Steve mentioned, that includes patients with a family history of gastric cancer, patients with a family history of H. pylori infection. We also focused on certain racial and ethnic minorities, as Stephen also mentioned. There's a lot of information from the Native Alaskan population about the high prevalence of H. pylori infection. Not so much off the top of my head, Steve may correct me here, but not so much off the top of my head with the Native American population in the lower 48. But I think given our expectation of the high prevalence of the infection there would certainly be a strong case for considering some form of mass screening.
Right.
Steve.
So that kind of falls now into almost a public health sort of approach to this.
Potentially, yes.
Yeah. Okay. All right. So I think you mentioned this. I think Dr. Howden mentioned this. And here's a question related to one of your earlier answers. Why don't all patients with dyspepsia get better after treatment for H. pylori?
Great question. I wish I could give you a definitive answer to that. As Steve mentioned, there are many potential causes of dyspepsia. That one of those is H. pylori infection, another is use of aspirin or non-steroidals, and then there are a large proportion of patients with dyspepsia who have symptoms for reasons that we simply do not understand. These are the patients with so-called functional dyspepsia, which is a disorder of gut-brain interaction. However, it's still worth testing those patients for H. pylori infection, even although only a minority will have prolonged symptom improvement. And the reason for that is the simple intervention of testing for H. pylori infection and treating it is still the intervention that produces the most sustained benefit in these patients. So I think we do a good service to our dyspepsia patients if we test them for H. pylori because it's one possible cause of their symptoms. I never promise the patient that the symptoms will disappear if we get rid of the infection. But if we get rid of the infection, we can at least tell them that one potential cause has been excluded or dealt with. And we probably have reduced their lifetime risk of more serious outcomes of H. pylori infection.
Right. Okay. So, and again, I think this is another one for you, Dr. Howden. Why is it necessary to stop a PPI for 2 weeks before doing a urea breath test? So maybe you can dive into that a little bit more.
Yeah, the simplest explanation for this is that the PPIs have an inhibitory effect on urease. So any test that's urease based, I should say, will have reduced sensitivity if the patient is on a PPI or has recently been on a PPI.
Okay. All right. Well, unfortunately, that's all the time we have for today. I'd like to again thank today's presenters, Drs. Stephen Moss and Dr. Colin Howden, for this excellent presentation, really getting into the ins and outs of testing and treating H. pylori. And I also want to big thank you to Meridian Bioscience for sponsoring today's event. Now, we will send all the audience questions received during today's event to the Meridian Bioscience team. If you have additional questions, please send them to me at webcasts@medcore.com, and that's medqor.com. Also, please email me at webcasts@medcore.com with comments, questions, even future webinar suggestions. We're always looking for good ideas. Visit us at clpmag.com and follow us on all of the major social media platforms. Thank you, all of you who attended live today, for taking the time to attend the CLP webinar, and please be well.